Hello everyone, today I am going to discuss about a type of a cardiomyopathy, that is hypertrophic obstructive cardiomyopathy. As I discussed in my previous video about dilated cardiomyopathy, so if you did not watch that video, please go to the link description as I provided. As you can see in the word hypertrophic obstructive cardiomyopathy, it suggests you that there is some kind of hypertrophy in the myocardium of the heart and which obstructs the blood flow of the heart. So, hypertrophic obstructive cardiomyopathy is the condition in which myocardium of the left ventricle hypertrophies, and this is not due to physiological stimulus, as we can see during the chronic hypertension and during the valve disorder. So in simple word, you can understand this like that there is an increased synthesis of actin and myosin protein due to the mutation, and this result into a cardiac muscle hypertrophy. The hypertrophy is mostly seen near the septum at the subaortic part, which obstructs the blood flow to the aorta, and this creates a pressure inside the left ventricle. This increased ventricular pressure over time can lead to concentric hypertrophy at the left ventricle. As you all know, and I already discussed in the previous video, that about the type of a hypertrophy. So in concentric hypertrophy, what's happened that the myocytes become thicker in size, where sarcomeres are added in parallel with the existing sarcomere. So that concentric hypertrophy results in a decreased compliance as ventricles become stiff and fail to relax, and this can lead to a diastolic dysfunction, as we all know. As you can see in this picture, there is an hypertrophy at the left ventricle, and I discussed that it is mostly near the septum. It is mostly at the subaortic region. You can see the aorta here. So it is mostly beneath the aorta at the subaortic region, but it is mostly found at here. But it is seen that the hypertrophy is also at the region of the apical part, and in some case it is near that mid-ventricular region, and in some case it is found diffusely over the ventricle. But in most cases the hypertrophy is found near the septum at the subaortic region. So you can make the picture in the mind that if there is an obstruction near the septum at the subaortic region, then what happens that it obstructs the blood flow from the left ventricle to the aorta. And what happens that over time this obstruction can create a pressure inside the left ventricle, and left ventricle undergoes the concentric hypertrophy in order to overcome that obstruction, in order to generate more force to overcome that obstruction. You can see in this picture that in concentric hypertrophy the sarcomeres are laid down in a parallel position in order to make the myocardium muscles thicker to generate more force in order to overcome the obstruction which is created due to the hypertrophy at the subaortic region. Let's discuss the etiology. It is seen that 60 to 70% of the cases of hypertrophic obstructive cardiomyopathy are run in a family, and it is due to the mutation. The mutation is due to autosomal dominant mutation at the gene which encodes the sarcomere protein. And the most notable affected contractile proteins are the beta myosin heavy chain and a myosin binding protein C, and these proteins are very important for the maintenance of normal cardiac function. Maternal diabetes can also cause hypertrophic cardiomyopathy in a newborn, but it is of transient type and it gets resolved over time. The basic idea here is that the excess sugar in a mother during pregnancy can deposit over the myocardium of the developing newborn. Concentric left ventricle hypertrophy is also seen in patients suffering from chronic hypertension and Friedreich ataxia, as during the chronic hypertension, due to the high blood pressure, the left ventricle undergoes hypertrophy. In Friedreich ataxia, which is a autosomal recessive disease, and it is associated with a trinucleotide repeat, and which also cause a concentric left ventricle hypertrophy and a septal hypertrophy. As we discussed in earlier slides, that in hypertrophic obstructive cardiomyopathy, there is an asymmetric septal hypertrophy of the left ventricle, and this hypertrophy makes the ventricle stiff, which fail to relax normally, and this can lead to a diastolic dysfunction. A thickened myocardium, which is due to the hypertrophic obstructive cardiomyopathy, obstructs the blood flow leaving the left ventricle. And due to the outflow obstruction, patient shows sign and symptom of the heart failure because the blood can't able to get out of the left ventricle, hence shows symptoms like dyspnea. Chest pain is also seen due to the outflow obstruction as the pressure inside the left ventricle increases, which decreases the coronary blood flow. And the one more reason also for angina is that the hypertrophic myocardium increases the oxygen demand, which result into angina like symptoms. Syncope is seen during the exertion, as during exercise the myocardium of the heart contract even more vigorously. So when the myocardium contract even more vigorously, the obstruction gets bigger, and when obstruction get bigger, the less and less blood will flow into the brain, and this result into a syncope. Because of the outflow obstruction, the pressure inside the left ventricle rises, and as the pressure inside the left ventricle rises, the blood which is present in the ventricle moves in a very high velocity into the aorta during the systolic phase, and which sometimes pulls the anterior leaflet of the mitral valve forward, and this is called a systolic anterior motion of the mitral valve, which over time damages the mitral valve, leading into a mitral regurgitation. It also causes a sudden death in athlete because the abnormal thickened myocardium increases the risk for ventricular arrhythmia, which intensify during performing exercises, because when we do exercises, our catecholamines increases the ventricular arrhythmia and causes a sudden death in young athletes. Let's discuss the clinical finding. The classical histological finding in this kind of cardiomyopathy is the myofibrillar disarray and fibrosis, where the fibrosed myocyte, as you can see here, the fibrosed myocytes with excessive branching run in a disorganized way. Normally we see that the myocyte of the heart run in a parallel and in an organized way. When auscultation is performed, as4 heart sound is heard, which is a late diastolic sign and which is normally seen during the left ventricular hypertrophy. Systolic ejection murmur is heard as blood ejects through the hypertrophic valve, and due to the mitral regurgitation, holocystic murmur is also heard. This is the echocardiogram image of the heart. Note the thickened septum as the blood moves from the left ventricle into the aorta, in which some of the blood moves into the left atrium as a result of mitral regurgitation. Let's discuss the treatment. It is very important to avoid high intensity physical exercise among athletes, as exercises increases the risk of sudden cardiac death in athletes. Medication like beta blocker and calcium blocker are beneficial in this kind of patient because both beta blocker and calcium blocker decreases the contractility of the heart, and which later on decreases the amount of thickening at the septum, and that lessens the obstruction to the blood flow. If patient experiences the symptom of syncope, then ICD is given to them. ICD, that is implantable cardioverter defibrillator, and this helps to reduce the risk of a ventricular arrhythmia. In severe cases, septoplasty is also done, where some of the septum is removed to relieve the obstruction caused by hypertrophic obstructive cardiomyopathy.